Hello, everyone. We'll get going here in just a couple minutes. Thank you.
Does it have to have the camera on? I need your camera device.
I got the slide thing, but I can't.
Good morning, everyone. Thank you for joining us today. This is Gail Bradley, Medical Director for Bureau of EMS and Trauma System. Just a reminder, if you're on the phone or computer, please make sure that you are muted so that we can make sure everyone is heard appropriately. We're going to go around the room and do a quick round of introductions.
Good morning, Lisa Viardwell, Medical Director for Preparedness here at the department.
Good morning, Eugene LeVar, Bureau Chief, Epidemiology and Disease Control.
Good morning, Kent Komatsu, State Epidemiologist.
Susan Robinson, Manager of the Vaccine Preventable Disease Program.
Nick Stodd, Medical Director for the Bureau of Epidemiology and Disease Control.
Shane Brady, Deputy State Epidemiologist.
I'm Ben Fisher. I'm the Services Section Chief for the Bureau of EMS and Trauma.
Rose Valera, Manager of the Preparedness Epidemiology Program. Great. So we are here today to talk about Arizona's COVID-19 response. And I'm going to start out and just give a little bit of a brief overview of what it's looked like here in Arizona. Then I'm going to hand it back over to Gail to cover some of the EMS specific pieces. Technology. Here we go. We're doing it. So this is a quick agenda of what we're going to be doing today. So a quick review of sort of what we've seen so far since the beginning, a little bit about the virus, COVID-19 by the numbers, and then I'm going to hand it over. We'll finish up with some EMS specific information. Just a quick heads up, everyone should be muted throughout this presentation. So if you've got questions, please use the chat box. We'll be monitoring those and we'll have time at the very end for some questions. So to start us out, this started back in December of 2019. In China, there was some reports coming through of cases of pneumonia with unknown causes. Initially, these cases of pneumonia were linked to seafood and wet animal wholesale market in Wuhan, China, which sort of initially led individuals to suspect there was some sort of animal to human transmission. As we progressed, there was a growing number of individuals who had exposure outside of this animal market. And so I think as we moved into 2020, we started to see more person-to-person spread in China. Once we hit January, we had identified the cause of this these pneumonia cases, and so it was a new or a novel coronavirus. And by the end of January, there were over 9,000 cases globally. Here in the United States, airport screening was initiated mid-January. It started with 3 airports and is now expanded out to 11. The first case of this novel corona was detected in the United States on January 21st, and that was in Washington State. And then by January 26th, Arizona had confirmed our first case here. By February 2020, the WHO has officially named this disease. So we first started out, and I'm sure you heard, novel coronavirus. And so we have an official name for this. It's COVID-19. By the end of February, there are over 50 countries with cases and over 80,000 cases identified. And this continues to grow and expand as we continue down. And then the U.S. had our first possible community spread of COVID-19 here in the end of February. This is a map. The WHO has done a really great job of helping us kind of get a picture of what's happening globally with COVID-19. They are putting out these situational reports, I believe, on a daily basis at this point, if not weekly. And so you can see that indeed a large number of these cases were in and surrounding China, but as you can see, really, this has expanded across the globe and is seen in a large number of countries. This is a great resource for some global information, so check out the WHO if you're interested in this level of information. Wanted to quickly go into information about the virus itself. So COVID-19 is caused by a novel coronavirus, and this has been officially named SARS-CoV-2. So if you hear those, know that SARS-CoV-2 is the virus that is causing COVID-19. So those two might be something that you're hearing. Coronaviruses are a very large family of viruses, and there are several coronaviruses that are known to infect humans, and sort of we find that they circulate during our cold and flu season. You'll see those circulating. And they can cause mild respiratory disease, which, like I said, looks a little bit like the flu. Coronaviruses can be found in animals, though, and some of these viruses do have that capability of moving between animals and humans. And like I said, person to person for some of those human viruses. A couple examples of these sort of starting in animals, moving to humans are MERS or SARS. So if you've heard of those are also two coronaviruses as well. We want to move into sort of what we know, and I'll preface this with saying we are learning new stuff every day. So to say that this is not going to continue to expand is silly. So what we do know, wide range of symptoms, and they vary from mild to severe. Symptoms can include fever, cough, and difficulty breathing. Just a quick note, this can look very similar to many other viral respiratory illnesses, especially like the flu, and we are certainly still very much strongly in the middle of our sort of cold and flu season here in Arizona. So just know that figuring out the difference by just looking at a person is going to be really tough to do. Information so far suggests that most COVID-19 illnesses are mild. And a report out of China suggests that serious illness occurs in about 16% of cases. And really what we're seeing with the 16% is we're finding the most severely ill are individuals who are part of our older population or people with underlying health conditions like heart disease, lung disease, and diabetes. And they are twice as likely to have some of these severe sort of disease progressions. The virus is spread person to person via respiratory droplets, and so this is produced when someone who's infected is maybe coughing or sneezing, and we come into contact with those droplets either directly, so close contact, or certainly there's the potential of sort of a fomite transmission, or having the virus be on objects, and then maybe you touch your nose or eyes or mouth and could potentially infect yourself that way, but person to person. There is currently no available medication to directly treat COVID-19, and there is no vaccine currently available to prevent it. Both of these are certainly being worked on and looked at globally, and so the hope is that we will see these both sort of happening soon. The great thing about this, though, is there are everyday measures you can take right now, and these are going to be things you're going to continue to hear throughout the presentation, and I think throughout this response. And so hopefully you're doing this proper hand washing when you can, covering coughs and sneezes with an elbow or a tissue, and staying home when you are sick. And so this is sort of when we're dealing with infectious disease responses, a lot of times we start with the concept of containment, and we're trying to contain the virus at its source. But over time, as the response expands and potentially as this virus expands into the community, we find that we need to move more into this community mitigation and preparedness component. And so I wanted to talk a little bit about this so that you all have an understanding of what this meant. So in the early stages of an outbreak, certainly like COVID-19, public health takes measures to contain the disease, to stop it from spreading into the community. And so that happens, we're trying to do really narrow and specific testing on individuals to identify who has got the virus. We're using measures like isolation and quarantine to keep people from transmitting into the population. And so this is really that containment stage where we're really trying to ensure that it doesn't go any further outside of our community. What we do move into is when we see that the virus maybe is spreading into our communities, we have to shift our the way that we are attacking the situation. And so we are shifting from a containment to a mitigation. And so we're going to be using different methods like social distancing. So staying home when you're sick, not going out to large gatherings when you don't need to, different things like that. Okay, so this is sort of where we stand right now and where we are moving to. I'm going to hand it over to Gail so that she can start talking to you all about some EMS specific guidance.
Excellent. Thank you so much for that background. So a big change from the previous webinar that we put on for EMS a couple weeks ago is that we are now recommending some PSEP guidance, and we'll get into why we're specifically making that recommendation. So one of the things that we've identified is right now we're in the throes of the respiratory season, but we're also seeing new information coming out daily in terms of a number of patients, where those patients are located geographically. And what we're recommending at this point is ultimately we want to limit the EMS personnel exposure because ultimately, as you'll see, that affects their ability to work. So the first step of the PSEP guidance is going to be really asking, does the patient have a fever or respiratory symptoms? The fever can be subjective or measured, and the respiratory symptoms include cough and difficulty breathing. If the answer is no, you're going to proceed to your routine PSEP screening. If the answer is yes to that question, the next step is going to instruct other people to distance themselves from the patient unless they're wearing PPE, and then notify EMS prior to arrival that they need to initiate some type of PPE. At a minimum, we want EMS to wear a mask of some type and gloves prior to coming into contact with the patient. And I think that's a really big step here, is prior to actually making physical contact, we want you to have your gloves and mask on so that you're not having an exposed contact with the patient. Ideally, if you have access to other PPE, we are recommending that you wear the additional PPE, which includes eye protection and a gown. We recognize that a lot of EMS agencies currently don't stock gowns and eye protection, as that does limit the availability. So at a minimum, if you can at least wear masks and gloves, that's great. If you're able to wear additional PPE, then ideally you should wear that as well. Immediately upon making patient contact, the next step would be to actually provide the patient with a mask, and we'll get into a little bit of what that means. This will be available on our website later today, and there'll be a link to show you where to find this information as well. So why are we recommending screening? So number one, we're seeing an increasing number of cases and increasing number of countries that are also reporting cases. we feel that EMS should really focus at this point on over-screening patients. Our goal is to increase the use of PPE by EMS and to provide a face mask to the patient for source control. PPE utilization and source control will help to decrease the risk of exposure for EMS personnel and reduce the risk of work restriction. So this guidance document is from the CDC. I'm going to focus more on kind of the category that we'd like to get EMS personnel into. So healthcare worker providers, HCP, HCW, or EMS are really referring to the same type of thing. This is someone who's working with a patient. And you'll see in the categories here that you have the exposure category, recommended monitoring, and we'll define what those mean, and also the potential work restriction for an asymptomatic healthcare provider. Our goal is to help EMS get themselves into the low risk category. You'll see on this slide and the next slide that if you are in the high or medium risk category, you actually this time will require active monitoring, and then you'll have work restriction from 14 days from the last known exposure to a patient. So that's not for the first exposure, but actually the last exposure to that patient. So that's a pretty prolonged period of time. So again, these other exposures, again, this will be available on the website. So we're going to focus more on the slides that are very specific of where we want EMS to get to. But if you have unprotected exposure to a patient, you would be in the medium risk category. And again, medium risk puts you into the active monitoring stage and exclusion from work for 14 days. So our goal with this kind of change in PSAP screening is to hopefully guide EMS to get into letter F. When you look at the screening, if the healthcare provider wears a face mask or respirator only and has prolonged close contact with a patient who is wearing a face mask, please note that a respirator is obviously going to confer a higher level of protection than a face mask, but per the CDC, they are grouped together in the scenario and classified as low risk because the patient was wearing a face mask for source control. So again, this is the key thing for the PSAP screening is if you wear a face mask and gloves and then you provide the patient with a face mask immediately, you will get yourself into this low-risk category, which means that you would have self-monitoring with delegated supervision. And if you're asymptomatic, you would not be restricted from work. So really that is our goal, is to help EMS be able to be out there in the community responding to other emergencies and not be at home for 14 days of exclusion from work. The other categories, with G, you'll see a healthcare provider who's using all recommended PPE, and they're caring for a patient with secretion. So again, someone who maybe is having a lot of coughing, you're doing some type of advanced procedure involving their airway or bagging that patient. If you're wearing your PPE, you're still going to get yourself into that low risk category. So again, the main thing with this is try to get you as the EMS provider to be in category F for your exposure risk. So prolonged exposure, so a little bit of information about this. When I see prolonged exposure, historically in my mind, I think of a lot longer period of time. Right now, there is not enough data for us to really determine what that time frame is. So the CDC is actually defining as prolonged exposure as less than 1 to 2 minutes, which is a pretty short duration of time. This is important for EMS personnel because really anyone in that EMS crew, if you're involved in lifting the patient onto a gurney, helping to load that gurney into an ambulance, you're going to get beyond that 2-minute time frame of patient contact. So we really want to focus on making sure that everyone's adequately protected, but also if you immediately provide that patient a mask, you will be under that 1-minute time frame, certainly under the 2-minute time frame. So that's part of the recommendation of why we want that mask on the patient immediately as soon as possible. So types of recommended monitoring. So per that CDC risk matrix, they recommend active monitoring, self-monitoring, monitoring, delegated supervision, or no monitoring at all. And again, the time frame for this monitoring period is 14 days after last potential exposure. So active monitoring would be the state or county health department assumes responsibility for communication with a potentially exposed healthcare provider to assess for the presence of fever or respiratory symptoms. If that provider is in medium or high risk, that communication should occur at least daily, and the method of communication is left up to the delegated authority. The health department can delegate that monitoring to the healthcare worker's occupational health or infection control. So self-monitoring with delegated supervision. So this would be someone who is ideally, again, if you get into that low risk category, the healthcare worker is going to perform self-monitoring with oversight by the occupational health or infection control in conjunction with the health department. The supervising organization should remain in close contact with the healthcare worker to oversee self-monitoring activities. And the healthcare worker should be monitoring themselves for the development of fever by checking their temperature at least twice daily, or development of any respiratory symptoms, cough, shortness of breath, or sore throat. So high and medium risk exposure. So these, if you have a high or medium risk exposure, currently the recommendation is active monitoring for 14 days after last exposure. It includes restriction from work in any healthcare setting, and if fever or respiratory symptoms develop, that individual should should self-isolate immediately and coordinate with their county health department to determine the next step of where to receive care. So low risk exposure healthcare providers should perform self-monitoring with delegated supervision for 14 days after last exposure. If asymptomatic, they are not restricted from work. Daily monitoring to ensure that they are afebrile and asymptomatic before reporting to work. So again, just recognizing in EMS, we do shift work. So if you potentially have an exposure, you wouldn't want to just check yourself at 7 a.m. if you're going into work at 2 p.m. So you want to make sure before you actually go into work that you're assessing yourselves for potential fever and any respiratory symptoms. An employer may check the healthcare worker as well for fever or respiratory symptoms. So PPE recommendations. So based on the available evidence, COVID-19 is considered to be spread by respiratory droplets between people in close contact and not by airborne transmission. So again, this is a big change from the initial guidance that we gave in the first webinar. The recommended PPE is a disposable pair of gloves, disposable isolation gown, a medical or surgical mask, which also can be increased to an N95, and some type of eye protection, which could include goggles or disposable face masks. So some specific patient care considerations. So again, the face mask should be worn by the patient for source control if COVID-19 is known or suspected. A simple medical face mask is sufficient for the patient. We do recognize that many EMS agencies do not stock a typical surgical face mask, and if the only thing you have available is an N95, then this would be another option to provide the patient. You would obviously try to find the best fitted N95 to the patient, which would be an approximation since they're not getting true fit testing. If you do need to place the patient on a nasal cannula, some type of face mask should be worn over the nasal cannula, again, for source control. And alternatively, an oxygen mask can be used as clinically indicated. So this would be another method that you could at least mask the patient and still provide supplemental oxygen. One other recommendation we are making now, which is new, is to limit the number of personnel who have direct contact with the patient and in the patient compartment to essential personnel whenever possible. So generally in EMS, we usually approach all patient care as a crew encounter. We're recommending with COVID-19 that we probably have the initial crew evaluate the patient. If the patient's stable, maybe limit who all is exposed to that patient to necessary personnel only versus the entire crew. So a big thing we wanted to mention is aerosol generating procedures. So this is where the CDC and WHO are recommending an N95 mask use. So some examples of aerosol generating procedures, it would be tracheal intubation, also supraglottic airways obviously fall into that category, non-invasive ventilation, tracheostomy, CPR, and manual ventilation before intubation. So if you're performing any of these procedures, you should have a higher degree of protection, specifically an N95 and eye protection in addition to your gloves and ideally a gown. One of the things that we have recognized is that not all EMS carries gowns, but I think most EMS has an OB kit. So worst case scenario, if you did have a situation where you had to intubate someone and did not have a gown, that would be one place where you could potentially get a gown to at least protect yourself prior to doing an aerosolizing procedure. So why the change in the type of face mask? Again, just reiterating that we feel per the current evidence that COVID-19 is not airborne spread, and so we no longer need to recommend N95 for all types of patient encounters. The WHO has developed guidance based on a consensus of international experts who considered currently available evidence as a mode of transmission. This evidence demonstrates transmission by respiratory droplets in contact with contaminated surfaces of equipment. It does not support routine airborne transmission. So just a reminder again, this is recommending that if you are doing any aerosol generating procedures, they are still recommending that you use the N95 for a higher degree of protection for yourself. And all these resources are also being supported by ADHS at this time. So these are all available on our current website. So EMS transport of patient under investigation or patient with confirmed COVID-19. So again, this is a situation where you may have a patient that has been identified as having had an exposure that needs to be transported. This is unchanged from our last webinar, but we wanted to reiterate this. So again, similar driver, if they have any direct patient care, which includes moving a patient onto a stretcher or loading that stretcher into the ambulance, they should wear all recommended PPE. After completing patient care and before entering an isolated driver's compartment, The driver should remove and dispose of the PPE and perform routine hand hygiene to avoid soiling the driver's compartment. If the transport vehicle does not have an isolated driver's compartment, the driver should remove the face shield or goggles and perform self-hygiene, and then put a new respirator on to perform transport. All personnel should avoid touching their face while working, and EMS clinicians should notify the receiving facility that they have a potential exposure based on history and signs and symptoms suggested of COVID-19. If family members do insist on riding in the ambulance, they should be provided a mask as well. Ideally, family members should drive themselves to the hospital. We recognize in the EMS setting that especially if we have a pediatric patient, that likely is not going to occur. So just please make sure that you provide any family member with a mask as well. So the other key pieces is to isolate the ambulance driver for the patient compartment, keep any pass-through doors and windows tightly shut throughout transport. On arrival, after the patient is released to the facility, EMS clinicians should remove and discard PPE and perform routine hand hygiene, and used PPE should be discarded in accordance with routine procedures. So cleaning of transport vehicles after transporting a patient. So a lot of this is based on the initial CDC guidance from February 20th. We have not seen any updated guidance based on this. But what we really recognize is after you've offloaded the patient, if you leave the ambulance doors open, this allows for good airflow through the ambulance, which will help with kind of clearing the environment. Based on the time it's going to take for you to offload a patient, do your patient care report and transfer of care, that should be a sufficient amount of time to actually air out the ambulance itself. While cleaning the vehicle, EMS personnel should wear disposable PPE. If there's any risk for splashing or sprays, that at that point they should definitely use goggles, some type of eye protection, or face shield. And make sure that any cleaning disinfection materials meet the CDC recommendations. Obviously, if you're cleaning, you want to make sure those doors are open, which again will help air it out as well. So there is an EPA-approved agent list that lists effectiveness in disinfecting against coronaviruses that is on this web link as well. These slides will be made available hopefully later on today as well. All surfaces that have been on patient contact need to be cleaned. This includes stretcher rails, control panels, floors, walls, work surfaces. Essentially, the entire interior compartment of your ambulance should be cleaned and disinfected appropriately. This is a list of some of the CDC resources and some additional resources from the WHO as well as ADHS. We recognize that this is an ongoing and rapidly changing situation, and so we do want to make sure as any new information becomes available, we will update the website. For those that generally go to the Bureau of EMS and Trauma Systems website, we have a link which then will take you directly to anything to do with COVID-19 or coronavirus. So that is kind of the link to take you towards that information. We did have some questions that were submitted ahead of time, so we will kind of go through some of those questions.
So we've gotten some questions about if an EMT is potentially exposed, who would pay for treatment and testing. Currently, the state pays for testing done at the state lab. A lot of these questions revolve around a potential occupational exposure. Who would pay for a potential quarantine after an occupational exposure or an illness? That would rely on the employer's sick policies. You would need to check with life insurance carriers or employers to verify life insurance and occupational benefits as well. If a patient shows the need for potential treatment and they were to refuse to cooperate wearing a mask or other protective measures, could a provider refuse to treat them? No, you do have a duty to act. Each situation varies, and we would encourage you to contact online medical direction as appropriate for the situation. This question is related to PPE shortages. As first responders, we're usually first on scene. How can we ensure we are using the appropriate PPE for a response? With shortages of medical supplies, how can we maintain safety if we don't have proper PPE? If your agency is experiencing a PPE shortage, please contact your local county health or tribal entity. Also, the Bureau has sent out a survey related to PPE needs that will be open through the end of the week through the Bureau's Gov Delivery related to PPE needs. So please respond to that through your agency as well. The next question is, does ADHS have specific recommendations for EMS agencies on limiting exposures for EMS crews with potential exposure during transport? As we discussed in the presentation, ADHS is following the recommendations of the WHO and recommending PPE usage to include gown, non-sterile gloves, eye protection or face shield, medical or surgical face mask, and then if aerosolizing procedures are to be done, an N95 mask would be appropriate. This next question is related to the incubation period. Has CDC been able to confirm the actual incubation period for the virus? The incubation period means the time between catching the virus and beginning to have symptoms of the disease. Most estimates of the incubation period for COVID-19 range from 2 to 14 days, most commonly around 5 days. These estimates will be updated as more data becomes available. How long can the virus live on an inanimate object? Currently, it's not certain how long the virus that causes COVID-19 survives on surfaces, but it seems to behave like other coronaviruses. Studies suggest that coronaviruses, including preliminary information on the COVID-19 virus, suggest it may persist on surfaces for a few hours or up to several days. This may vary under different conditions, such as the surface temperature or humidity of the environment. If you think a surface may be infected, clean it with disinfectant, simple disinfectant to kill the virus, and then protect yourself and others. Clean your hands with an alcohol-based hand rub or wash them with soap and water, and avoid touching your eyes, mouth, or nose. And then this last question is, have any EMS personnel in Arizona had a confirmed exposure to the COVID-19 virus? Yes. They are being contacted by the county health department, actually have been contacted by the county health department as part of the contact tracing process. And then the final question is related to, we've had some questions about PPE and Tyvek suits and sort of what PPE is recommended. Again, we are recommending the gown, gloves, and surgical mask. At this time, that's consistent with the WHO recommendations. We are not recommending the Tyvek, the complete Tyvek bodysuit. Per the WHO recommendations, a gown, gloves, mask, and eye protection are sufficient because of the recommendation that it's transmitted by respiratory droplet. The PowerPoint and then this recorded webinar will be available. The recorded webinar will be available on the AZDHS YouTube page at some point either later today or tomorrow, and the PowerPoint slides will be available on the AZDHS/coronavirus. There's an EMS and 911 page specifically. We'll make the slides available there. Both of the confirmed cases were in Maricopa County in Arizona.
There's a question about the best source. So I think really looking for those reputable sources. So CDC is going to be a great source of information for local. Some of the counties have stood up websites, so those are available, and we're doing our best here to keep our website up to date. And so those are really going to be your best sources of information for this response.
So it looks like there's a question to clarify which mask do you recommend for EMS? For routine patient care, so non-aerosol generating procedures, a simple surgical face mask is sufficient. If you're going to do any type of aerosol generating procedures, we do recommend that you use an N95. Alternatively, if you only carry N95, then that's the only mask you would wear for any type of patient encounter. There's another question. I'll see if someone else in the room wants to potentially answer. Has ADHS considered an expanding screening process for the public? Some cities and states have done drive-through screenings.
I'll take that. So ADHS and our county health departments are working based on the new PUI criteria for testing that CDC released. So currently at this point, CDC and our state public health laboratory are the only ones that can do the testing. And so we do have limited reagents and testing capacity. However, we do know that some commercial labs are going to start onboard testing in the next week or two. So that may kind of expand some of that testing across the nation.
Hi, there's another question in the chat box here. Is the state going to be able to help supply PPE due to the shortages? Just to let everybody know, we are closely monitoring on a national and state level what's going on among our healthcare providers and their PPE and other supply needs. So what we would recommend is if you're experiencing any shortages or difficulties acquiring appropriate PPE, that you work with your local health department to let them know about the issue, and what they can do is see if there's any assistance available in your immediate area, and if not, they can express those concerns to us at the state level, and then we can go ahead and see if there's anything we can do to assist moving forward. So what we would like you to do is, if you are experiencing those difficulties, is to work with your local health department. Thank you.
And again, that is why we've asked people to please fill out that survey. The survey is asking which county your agency works in, so that way we can gather information regarding shortages and help provide that information back to the counties as well.
There's a question about whether or not a patient is only contagious when they're symptomatic with fever and cough. And as we learn more about this virus, we will know more about the asymptomatic period, or that period of time before they develop symptoms, and whether they're contagious. At this time, we're considering that a patient is most contagious while they have symptoms of fever and cough. So that's why we're limiting our recommendations to to protect yourself when the patient is most contagious.
There's another question regarding whether or not SVNs are considered aerosol-generating procedure. Someone tell me what that is.
Computer hall nebulizer.
So depending on the device that you're using, most of the SVN devices are going to have air that is coming out the back end of it. So I would say that yes, that is an aerosol-generating procedure, unless you're using some type of closed space. But again, non-invasive ventilation. So if for some reason you had an SVN going in through a CPAP device, you would still be doing non-invasive ventilation at that point, which would be aerosol generating. So I think either way, you're looking at the likely aerosol generating procedure, which is a recommendation for you as EMS personnel would be an N95 mask.
If it wasn't answered already, yes, the PSAP flow sheet will be posted on our website later this afternoon.
There's a question again about when we'll be able to get more N95 masks. Please, if you are out of N95 masks, notify your county health department immediately. There are resources to get them. So that is one of the things we are trying to get in the survey. But if you are low or out of any PPE supplies, the first contact point for you should be your county health department. I did get one question as well regarding use of N95 on the patient, as the patient is not fit tested for the N95. We understand that is not ideal, but if you do not stock or have any surgical masks at this time, you are at least providing some type of source control for the patient. So our goal right now is to really limit your risk and exposure to get you into the low risk category. So a fit tested N95 for the EMS personnel and gloves, and then an N95 if that's all you have on the patient. Again, best size to the patient as possible. So you'd likely need to take a few different size masks in before you go into the patient to kind of get a gauge on what size they would wear.
We're getting questions for contacts for county health, and so that can be found on our website on the page provided up above on the chat.
We had another question, should PSAPs use the screening questions for law enforcement only related calls at this time so as to protect officers from potential contact? Again, if law enforcement has access to PPE, it's certainly reasonable. I'm not sure if they would be going out on kind of respiratory type complaints. I think this is really more on a medical type complaint, but certainly it is not unreasonable for anyone who feels that they're coming into contact with someone who is potentially ill to use PPE. Again, that's going to be in your availability of resources.
And that's, we did have a law enforcement specific webinar earlier this week. And that was sort of what we had discussed with them as far as PPE that would be for them, which is really that face mask when available. So that should sit right on par with what you have just been told.
So we have a question regarding if you are having difficulty contacting your local county health department. I would recommend that you try contacting them once again. Unfortunately, they are their own entities. We can only kind of point you in that direction, but I would just try contacting them again. So next question. When transferring patients from remote regions, do we have any reason to prioritize particular receiving/tertiary care facilities? At this time, we are not recommending bypassing to a tertiary care facility. Really, any emergency department should be able to take care of the patients in this manner. We did see the follow-up question from a couple individuals that are having some difficulty. We will reach out to you privately to figure out who you're having difficulty contacting and make sure that you have the right point of contact at the county health department. So there's a question, if we do CPR or other procedure on a patient who is not a suspected patient, should we use the N95 as a matter of course of protection? In general, your typical PPE that you should be wearing anytime you're doing CPR, there is a high risk of exposure. So generally, your routine PPE should be in place for those scenarios. If we do not have any further questions, we will bring this to a close. We really appreciate everyone's participation today. All right. Thank you very much. We hope you have a good day. Please feel free to reach out if you have any questions. Thank you.